There have been so many changes in general practice over the past few weeks that we're going to be rounding up what has happened. We've got some amazing stories that if you haven't heard about them, you'll be shocked. And if you have, well, we're going to go into them in a little bit of depth to try and update you on what's happening in general practice, technology enhanced primary care and learning, as well as PCN stuff. And we've got some amazing news, including possibly one of the biggest buyouts in UK healthcare going. Let's take enhance your primary care and learning. Hello, eGP learners, and welcome to this episode where we're talking about basically all the updates that have happened in general practice over the past few weeks. And we have got some massive stories to talk about, haven't we, Andy?
Yeah, some big stories coming up this morning. I guess just to give people a heads up, what we're going to be talking about, what's going to be happening. So there's been a big buyout of a large clinical records provider, which we'll be talking about in a little bit more detail. There's been the NHS Confederation Expo in Liverpool over the last week. So there's been some key talks and speeches by individuals, and we'll be looking at things that Sajid Javid has said, that Nikki Kanani has said about health inequalities and funding as it relates to that. There's also been a big story about Physicians Associates and one of the large private GP providers, the largest, in fact. So we'll be talking about that in a little bit more detail. And of course, I've been trying for 2 years to get my total reward statement for my pension. I was hoping that maybe a new provider might help me get that and understand where I'm at with my pension, but Capita have got the contract again to provide the PCSE contract. So we'll be talking about all of those things and more, I guess.
Yep. And
Exciting,
as
Gandhi?
always, and if any of our viewers want to jump in and join us on these discussions, absolutely feel free to do so. So we're already seeing lots of stuff in the comments and stuff. And I'm going to start off by asking all of our live viewers, do you use EMIS? If you do, put a thumbs up in the chat and stuff, because that's what we're talking about in our first section. So shall we lead into it, Andy?
Yeah. I mean, neither of us use EMIS, do we, actually? Although I have used it before and I was quite impressed with EMIS Web.
So interestingly, I've used EMIS a couple of times. Predominantly, yeah, you're right, System One, and many of our EGP learners know that you and I basically run the System One user Facebook group, as well as the conference that we do for the users with System One and TPP. And just a bit of sneak information for that, we will be doing a conference this year. It's a little bit later than planned, but it's going to be probably in September and stuff. But have used EMIS a few times previously, both EMIS LV. Yep, that ancient kind of software and stuff. EMIS PCS, which in my view is probably the worst iteration of EMIS, and EMIS Web as well. But the reason we're talking about this is basically one of the largest buyouts in UK primary healthcare has just been announced and stuff. And this is hot off the press. This is news from yesterday and things, and it's massively hitting up on the media channels and stuff. But basically, a company called Optum UK is set to buy EMIS at an estimated $1.5 billion. That's about 1.2 million pounds, I think it is, something like that. 1.1 million pounds, something. Um, and it's a bit interesting because Optum is a branch of a group called United Healthcare Group. And this is one of the largest
Oh, we
largest
lost
companies in the
Gandhi.
world. Sorry?
We lost you there. We lost you there for a second, Gandhi, but you're back. So that's it. Carry
Okay.
on.
Yeah,
You were
so
telling
don't
us
know what
about
you guys caught.
telling us about who owns Optum. Carry on.
Okay. So Optum is it's a branch of a company called United Healthcare Group. United Health Group. And they are the 8th largest company in the world. I think they're the 2nd largest medical healthcare provider in the world as well, based out in Minnesota, USA. And yeah, it's an interesting proposal basically, because they're paying a fair amount for the company itself, a little bit over the odds in some thoughts as well.
Yeah, I think we
What
got a
did you
tweet
think?
from Simon Eccles, hadn't we, just about the valuation placed on EMIS, which I'll just pop up. So just tell us who is Simon Eccles and why should we care what he thinks about the valuation of EMIS and what are we seeing here?
So just to point out that this is his commentary. So Simon Eccles is the former Chief Clinical Officer of the NHS itself. So he's not in that role currently. And I guess this is just a live tweet that we've seen. So, he mentions that it's possibly a large payout for potentially suboptimal software. It's just questioning the payout levels. And I know this is, when you look at all the chat and stuff and things that is happening across medical Twitter in particular, lots of questions being asked about why they're buying out EMIS, basically. What's the reason for it? And it's quite pertinent, I think, because coming up in a couple of weeks' time from when we film this, it is the EMIS user group conference, which I'm actually presenting at. So slight declaration there that I'll be there and talking about how to enhance your primary care tech and that kind of stuff. Rather interesting because, as I said, I don't typically use EMIS and things. Um, but yeah, it's an interesting purchase, shall we say, because it's pretty significant. And I think in particular the past few years, having been on various groups and supporting lots of people, there's always these comments about how much investment is actually going into EMIS and how effective the support and the software and stuff is. And is this a good thing? Is this a bad thing? I don't know. What are your thoughts, Andy?
Got a few thoughts really. I guess private investment doesn't always equal bad, I suppose, or not. That's not
Mhm.
a universal truth. Often private companies have deeper pockets with which to invest into the companies, improve the products, improve the reach of the products, onboard more users to the ecosystem, so that you get some strength in depth and network effects. So it's not necessarily a bad thing. I suppose on the flip side, you have to wonder why these companies want to make these acquisitions, and often what companies are doing are buying up different unrelated companies that they can kind of put together to get some
Mhm.
synergy, so that the value of them to them is more than the sum of their parts because they work together well. So I guess you think about some of the access they have into markets, ICSs and so forth. Maybe they can sell the products in. Maybe there's something they can do with the data together with their other assets
Mhm.
if they unlock it. But it's interesting, not necessarily a bad thing, but I guess we always just have a tendency to be suspicious of these large multinational companies. And to be honest, I'm never quite sure whether that's the right place to land. Nonetheless, I do feel that suspicion. What do you think, Andy?
Well, I think it's interesting because EMIS, we talked about this previously in one of our earlier episodes a few months back, how there seems to be this, what's the word, harmonization of companies across the whole NHS, particularly in UK healthcare. And this was spurred by the acquisition of 14 Fish by EMIS, which by definition, I'm guessing, is now going to be owned by Optum and, United Healthcare. And EMIS have, in the past few years, been purchasing various other companies. So I think there's Edenbridge, if I remember rightly, which was a patient access portal for many practices as well. So there is that acquisition that's happening. And like you say, is it the fact that it's the sum of the parts is what's making the value to United Healthcare Group? And I think because of that, you know, we don't know any other details apart from the fact that there's a purchase plan. I think it still has to go to the shareholders to be approved. But given the fact they're paying nearly 50% more than the share value worth, it'd be surprising if they turn around and said, "Well, we're not going to take the extra money and things." But it does raise the question, I think, in my view, about the data side of things in terms of what is the plan for this kind of purchase and stuff, and why United Healthcare Group so interested in this company. Is it because they're after the access to the data, which theoretically they shouldn't be able to use because they shouldn't be able to access, that for another resource and stuff. Um, but it has raised questions across the medical community about the motives. Absolutely.
Again, we've got an interesting comment from Janine BT. I think it's commented on the show before. I might just bring that up because she's just
Yeah, sure.
highlighting that the Optum, so the company in question that's bought EMIS, were commissioned to the population health program for them in recent past, which I think is interesting, and that's where I guess some of that access to the data and experience, kind of using that data, might enable them to more successfully bid for those kind of contracts in the future, which is interesting. Other
Hmm.
observation is now, is it Sentium? I always forget Operose Health's US.
Centene.
Centene, that's it. So they're the US parent company of Operose Health. And it was interesting because Operose Health did quite a lot of um, data work around what sort of became population health sort of
Hmm.
strategy in Nottingham. And then, before too long, they were acquiring GMS contracts and GP practices in the area. So it's interesting. And you can see how you have a lot of synergy if you own GP practices and the operating system they run on and so forth. So, yeah, it's interesting times. I'm not saying these are good or bad
Hmm.
things, officially on the podcast, but, it's just interesting to see what's happening.
Yeah, I think we can't really comment much on the deal itself, but apart from the fact that it is likely to happen from the information that we have. I think whether there's going to be, I think many people would hope that this kind of investment will lead to a more effective clinical system, because often I'm hearing gripes from many people about how the systems work. I mean, you and I have often been, commenting to TPP, who we do some work with, in terms of how that system can also be improved, and that's one of the reasons why we've been so involved in trying to support it. The changes that happen within the systems as well. Um, but we know that IT massively drives a lot of the efficiency within the healthcare systems, and when it's not efficient, it makes life so much more difficult. So having decent IT and tech, and in particular interoperability, can really lead to effective healthcare and probably solve a lot of the challenges that we are currently facing in general practice. And be really interesting to see what this potential buyout is going to have in the future in terms of supporting those changes. And definitely several people have commented about the fact that that could help. So Andrew Lloyd has commented it could be good. It's often very slow, and I'm assuming he's making reference to EMIS there. And Paul Atkinson mentioned that he's used all four systems where he works, and he only uses EMIS and TPP now, which are the market leaders in terms of general practice electronic health record systems, but used by practices. I think between them they own about 90%, particularly in England, and stuff, and possibly even broader than that. So
So
yeah,
again, do you think someone's going to be coming to buy TPP next? The owners of System One. Could this be the beginning of a round of acquisitions in this
I don't know.
sector?
It'd be interesting to see if that happens, and you never know. They may tell us at some point. I don't honestly know if that's something that's planned and stuff. But I think we are seeing conglomerates looking at purchasing. I mean, we see this across the whole spectrum, don't we? Amazon, Google, all the big tech companies. They find it easier to purchase smaller companies that are doing things, and obviously they are in the ecosphere in terms of the biggest kind of companies and stuff. But we've just seen the eighth largest company in the world buy a UK healthcare provider, software providers, outright. So are we? Who knows? It makes it interesting to see new entrants into the market. So, I am aware that there are some new entrants coming into the market when it comes to electronic health records. People like Eva, who we talked about before, in terms of that they're looking at developing a new EPR system, and I wouldn't be surprised if there's more to come, because actually, I think we really could do with, modernization of some of the systems that we've got to be more user friendly, at the very least from the clinician's perspective. And that's what I'm going to talk about from the clinician's perspective. But it'd be interesting to see what happens in the future.
Yeah, absolutely. Final comment. I can see some of these companies. If you were a company and you saw we're going to get to changes in the models of primary care later on, but maybe we're moving to things that happen more at a neighborhood level, more at an ICS level. If you wanted to build an out of the box, I can run a health ecosystem. You kind of need clinical records system provider in your toolkit. And I wonder if there are some big companies out there just wanting to become the the one-stop provider for some of these ICS, ICB level systems, and maybe that's what people are doing. They're the position that these big companies are positioning themselves to be ideal providers for what a future NHS might look like. Oh, who knows? Shall we move on to the next story, Gandhi?
Yeah. So next we're talking about the NHS Confed conference. So this is a group that supports innovation and hopefully change within general practice. They had their annual conference, so first time they've been able to do it face to face for a while because of obviously all the COVID stuff and things. And they had our Secretary of State for Health, Sajid Javid, turn up, and he made some pretty bold statements, didn't he, Andy?
He did, yeah. And I think it's interesting to take these within the context of other recent announcements coming out of people from NHS England and people in the know, including the full stock take report and other things. So what was Sajid Javid saying? Well, he was saying that the current model of primary care is not working, he announced to the audience at the NHS Expo conference. Just making being very thankful for people that work in primary care and the individuals, and they're making a big difference and so forth, but he thinks the current model isn't working. There are plans coming to address this. He says we need a plan for change. He's going to start with pharmacy, apparently. So I'm not. So maybe we'll get an indication of the wider plan from
Hmm.
announcements made about changes to pharmacy. So I think that will be interesting. Other voices that we're familiar with, so Amanda Pritchard, she's NHS Chief Executive saying that the current model of general practice isn't working as well as it should. So slightly softer coming from Amanda, but still a very similar message. It's not really much indication in terms of what was said, I think, at the conference about what might be coming, but we know that Sajid Javid has wrote the foreword for the At Your Service report from a think tank earlier in the year that was suggesting that the model for general practice needed a shake-up, and one of
Mhm.
the things that seemed more prominent in that report was talking about a GP salaried model employed by NHS trusts or other similar organisations. I remember when we looked at the Fuller Stocktake report, they were actually talking about activity at neighbourhood and ICS level supported by organisations like NHS trusts, GP federations, other larger organisations. So it feels like the mood music is being set by those in the know for a big change in general practice model coming
Mhm.
down the line. Um, I don't know what's your take on this story, Gandhi?
I think it's sound bites initially.
It
It's
is.
just to stir the pot. And we know that Sajid Javid unfortunately likes to do that. He likes to push the sound bites, and it seems to be his repertoire in terms of sound bites potentially over substance at times. And I think one of the things we're going to have to wait and see is what the plans are. I think what often, unfortunately, our Secretary of States in recent history seems to forget to do is mention the challenges as to the reason why general practice may not be working as effective as it could do. The fact that it's had serial lack of investment for the last 10 years or so, and even things like the PCN-DES contract have not provided the investment, I think, in the way that could have been more effective. And I know I say that absolutely as a PCN clinical director because actually, there have been additional challenges, not least COVID, but actually workforce is the biggest problem. The reason why general practice is struggling so much significantly is workforce and workload. And I don't know. I don't know if he will make anything that suggests that that's going to change imminently. Yet again, it's always about structure rather than the actual problems more than anything else. So it'd be interesting to see what his plans are. And as you mentioned, he wrote the forward for the At Your Service plans, which many people, particularly within the profession, have felt have been controversial at the very least in terms of the way that's been drawn up and stuff. And yeah, I think we're still gonna have to wait and see what he comes up with as ever, and as ever, the devil's always in the detail. But it does suggest that he's got a plan to change things, and how many times is general practice going to keep changing? To be honest, that's the challenging part. It seems it's just on the change roundabout for forever, and is that the reason why it's actually so much challenging? It doesn't have stability. It's all about access and change. And
Hmm.
on that point, I'm going to bring in John's comment here. Primary improvement would be stability, then speed. So I think that's a really useful comment and stuff.
Yeah. I think also there's quite an insightful question from JC Melody actually, because we often sort of moan and grumble and complain about sort of being done to and
Mhm.
changes coming and we're not necessarily asking for it and so forth. But JC asked what improvements would you like to see, which I think is a really good question and just got me. I saw that and I was just stumped for a few seconds and then I thought, well, actually, we probably need less change and actually to stabilize what we've got and sort of fund what we've got effectively and do what we already know works more effectively, which might sound a little bit vague really, but probably just slow down the change in a way and double down on what we think works. And Gabby, can we just share the screen? I just want you were saying lots of comments at the moment, lots of rhetoric,
Mhm.
and people may or may not be familiar with Overton's window. Are you familiar with this, Gandhi?
No, I'm not. So talk us through it.
No, so it's something that I've heard this come from kind of political science, kind of that kind of area and media type people. But essentially, it's a principle, and you can use tactics to shift what people consider being reasonable. So the idea is that when you're talking about any particular um, issue, and let's say NHS ownership, there's a range of views to the right and to the left, which kind of are acceptable to talk about and that don't sound ridiculously radical.
Mhm.
Um, and discussion tends to be within Overton's windows, and the sort of solutions that you tend to get come out of discussion in Overton's window. And what you can do, apparently, as a tactic, is if you want to shift Overton's window, you just start talking about something which is previously unthinkable. So
Mhm.
bring the discussion right out here to the far right and say, okay, we're going to scrap the NHS and it's going to be completely privately owned. And you start talking like that might be a credible possibility. And that kind of can shift and move and widen Overton's window. And then actually, what the policy that actually happens might actually lay somewhere which was originally outside of what people thought was kind of fair game and on the table. But you've widened Overton's window, and then you don't actually follow through with quite what you've said, but actually you get something that's closer to what you ideologically might have wanted because you've deliberately manipulated and widened Overton's window. That's
Mhm.
something. So I just wonder if there's a bit of they know all about this, the politicians, and I wonder if there's a bit of the they're handling the discussion and deliberately manipulating things potentially, and it wouldn't be above politicians to do that, and to a certain degree, that's their job.
True. It'll be interesting to see what does come out, and obviously when it does come out, I'm sure you and I will be breaking it down as best as we can to help explain it and stuff. So definitely make sure that you're all stay tuned to the channel for that and subscribe. Just on that, I told Andy about this just before we started. We've hit 9,500 subscribers, so help us hit that 10,000 barrier, please, by clicking subscribe to the channel, whether that's on Facebook or YouTube or whatever. But I guess JC asked what improvements would we'd like to see. So you mentioned obviously some elements of stability. I know one that you and I have been banging on about is actual definitive support for health inequalities, because often the contracts and stuff don't seem to drive that. And in actual fact, I know in particular I've been really critical about some parts of the PCN which have I feel driven health inequalities, like for example the vaccination aspects of the IAF and QoF and that kind of stuff, that they actually help drive further health inequalities by the way that they're structured and funded, which is interesting because at NHS Confed we had another story talking about that, didn't we, Andy?
We did. So this was Nikki Kanani speaking to the audience, and she was actually calling for a genuine shift in the way that we fund GP practices to support practices in deprived areas and begin to address some of these health inequality um, differences that we see. So she was sort of calling for a shift in the contractual framework and the actual formulas that allocate funding. She was talking about the Cahill formula and that doesn't necessarily support inequality in a way that many of us thought it would. Actually, I actually when I first started, I thought that Cahill actually did a lot to redress funding based on health inequalities and deprivation, but actually it doesn't. Most of the weighting is
Mhm.
just around age demographics. It doesn't actually take into account inequality at all. Pulse just link at the bottom of this article to a further study from 2019 that sort of found that for every 10% increase in a practice's index of multiple deprivation score, their payments, according to the Cahill formula, actually just increased by 0.06%. So really, almost a negligible
Yeah.
amount. So the Cahill formula and the current ways of addressing the things that when we say how is health inequality addressed, a lot of people say that the Cahill formula, they don't understand that it doesn't actually address health inequality very much at all. So she's sort of indicating that those mechanisms don't work, and if we're serious about improving health outcomes for those patients who are registered with practices in areas of high deprivation, then we really need to look at those funding formulas. And I think she's
Mhm.
effectively saying that that's on the table to be discussed, and that it needs changing. And I think, given the position that Nikki's in and the insights that she has, I think that there'll be some movements to address that. She acknowledges it's not necessarily easy to do, because for every sort of winner, people that get more
Yeah.
funding for the population in their area, there are losers. People who lose out on funding or don't get the same level of increase in funding that's coming, and
Mhm.
those people, and those populations in that area, will not be happy about that, and you can
Yep.
completely understand that. So it's a difficult one to square, but I think if everybody is genuinely serious about addressing health inequity, then I think it's something that needs to happen. But I work in a deprived area, and so do you. What do you think, Andy?
Yep. I think you're right. It's a whole question of it. It seems like this has always been in the too hard to tackle box of everybody's agendas, and that's why it's just continued to bumble along. Many people have commented that Carhill formula is outdated in terms of the function it's meant to provide. It's meant to tackle inequalities in funding, and the fact that it doesn't include elements of current modern health inequalities, like, for example, the challenges patient face in transport and stuff, in terms of accessing healthcare, in terms of resources that people have, in terms of non-English speaking, those factors that do massively impact health inequalities are not accounted for in the Cahill formula effectively. And the majority of it is around age and polypharmacy and that, and
Yeah,
complexity.
it's about disease. So there's some element of disease burden as well.
Yes.
But obviously, that study demonstrated that that doesn't necessarily mean that people practicing in deprived areas get more, get more
Mm.
money as a result of the Carhill formula. So
Yeah.
interesting. Can I speak?
And a comment we've had about that further, I think, exemplifies it. So Jonathan H comments, read the Cahill formula. It didn't work to address resourcing deprived areas. From memory, these areas were an MPIG correction, which was an additional funding tool that was used, which has now been removed. So they removed MPIG because they felt that that in itself was an inequitable way of funding practices, which, many places, for example, also had PMS contracts, which, for those that don't know about the contracting mechanisms of general practice, in real brief, there's generally three types of general practice contracts. There's the GMS, which is the main contract. There was PMS, which is a personalized medical service, which is like a locally derived contract, and APMS, which was traditionally used for takeover providers and that kind of stuff on a short-term basis. But PMS and APMS contracts are being phased out because they generally want one contracting model, and that's the problem. You can't apply one model to every single area, so there needs to be some element of balancing mechanism, and that's what's been removed. So I think there are massive challenges with this, and I think Nikki citing the fact there are going to be winners and losers in this is absolutely sensible. It raises the question why it's not been dealt with, and like I said, I think it's probably because it's always been that too difficult to tackle box, and possibly because the political shortfall from this, that actually changing these kind of things from both sides, from NHS England and the government side, but also from the general practice side in terms of the BMA, the GPC, and that kind of stuff. I think it is it's a powder keg, it's waiting to happen in terms of the debate and the shortfall and then the fallout. Sorry, from that, akin to we've always talked about why is there never a debate about paying for healthcare in UK, because it's a powder keg debate that if it happened it would be a nightmare to manage, coordinate, and understand. But actually, this is just as much of a challenge, I think, because it has so many implications in terms of the impact that it could have. It's nice to see it being on the agenda, though, to be honest, from my perspective. And obviously, as you mentioned, Andy, you and I are slightly conflicted on that, whether we both work in deprived areas.
I mean, our practices are likely to benefit from this sort of change. It reminds me a little bit of the debate around
Maybe,
school.
maybe not.
It reminds me a little bit about the debate around school funding that occurred a few years ago, because there used to be quite a good, pupil premium, didn't there? For that meant that there was some redistribution in education funding. Correct me if I get this wrong, but my understanding is that schools received more for educating pupils with a more deprived background compared to students with a more, affluent or standard background. And actually, a lot of people in a lot of areas of the country didn't like that because they were receiving less relative to people in other areas of the country, and actually they lobbied to have that reduced, and it was reduced. So these are really difficult policies, I think, to get through. You moved the debate on from MPIG, which I'm not going to go into MPIG, but I remember we were one of the most deprived practices in Nottingham City, and we had one of the smallest MPIG uplifts across Nottingham, and I think I'm not sure that it did actually address that, although it was
True.
additional for some practices, which was obviously very welcome and was removed. Can I show a picture, Gandhi? In fact, I have, because I've still got control of the screen. A lot of it, loads of people have seen this picture because it's becoming really popular now. And I'm not actually sure who produced it. So, credit to you. And if you want us to remove it, I guess we can blank it out. But I think we are making a very good point with this. And this is part of the debate moving on, I think, from equality to health equity. So equality is about everybody having the same, okay, everybody gets the same funding of their health, from the government, or everybody has access to the same clinics, as the government. And the trouble is, some people are really able to take advantage of that. They're already quite tall, they're quite interested in their health, they're motivated to do that. And some people aren't. And even if you give people the same, it doesn't mean that you get the same outcomes. Sometimes you have to give more resources. So what you're looking for is, rather than equality of access. Actually, maybe what we need is equity of outcomes. You know, everybody can see the ball game, everybody can look after their diabetes, but to achieve that, you sometimes need to help some people more than others. I know
Hmm.
this shift in thinking and a shift in my own thinking about, you know, health inequality, and actually to think more around this term of equity, and actually some some patients, you know, some practices to get the same outcomes for themselves and their patients might actually need to provide their patients with a lot more support than people need in other areas. So I really love that picture.
Yep. And there's actually another version of that that then talks about justice as a concept, and justice is where you remove the fence in the first place.
Oh gosh, if only. If only we could do that. Yeah, it all gets quite philosophical at a certain level, doesn't it?
Absolutely.
But you're absolutely right. So, Gandhi, um, I saw a story in the media this week that made me think of you and your area. Actually,
Hmm.
there was a lot of interest in physicians associates this week because the BBC had ran a sort of expose story that resulted in a panorama episode looking at the use of physicians associates by a large sort of multinational company that actually is the biggest sort of single owner of GP surgeries, GP surgery contracts in the country, Operose Health. And it got my attention because we've got some Operose Health practices working within my primary care network. So I've got experience, you know, working with those people who run those services. And I'll make some comments about that later, actually, because
Hmm.
it's not all bad, you know, some positive things to say, really. Um, and physician associates. And I know that your primary care network actually makes quite, you know, has begun to make use of physicians associates. So it really made me think about you and those people, those poor people working at this practice in my area who can't have had a good week.
Hmm.
Andy, I haven't watched the Panorama episode, but I know you have.
Yep.
What was happening?
So, I mean, the episode talks about this investigator. So, Julie Whitfield, I think it was. Apologies if I got the name wrong. I can't quite remember.
Jackie.
But she basically took on a job as a receptionist at an Operose practice, and it doesn't say which one, but it suggests it's probably one of the ones down based in London and stuff. And it talks about her experience in terms of, you know, working at the practice and the impact that has, and very comment and critical at points in terms of the way that the Operose structure seems to work. Now, both you and I don't work on Opero's practice or have any affiliation with them, and it is very much leaning towards that the processes and the way that the Opero's practices are functioning and not safe potentially even. And they've got commentary from some fairly eminent GP. So I think it's Sam Everington and Helen Salisbury, who have commented on the processes that they've been shown and what they look like and stuff, and the impact that has. And I think from my perspective, it shows some aspects that, you know, are not nice to hear about. Let's be honest on that. But I think for me, the key thing that comes up is this way that it views PAs and how the documentary has basically singled them out as possibly part of the problem, when actually, if you go by what the report says and what the program goes by, it's more about the supervision of the PAs that's the issue, not necessarily the skills of the PAs. Because I actually think PAs can be really effective. I think, you know, it repeatedly says lesser trained in the program and stuff, and I think it's important to remember when you compare PA to a GP, there is absolutely a difference in training there because of time, experience, and stuff. But does that mean that PA can't do an element of the job? Absolutely not. Actually, they're trained to do some aspects, but it's when you're asking people to work well above their competencies, well above their training, that's absolutely when you need to question, you know, is that an effective way for that person to be functioning and things? And, you know, I'd hope, you know, and speaking to the PAs that work in my practice, you know, that they're not in that situation. You know, we instill massive amounts of debrief support, and, you know, they know if they've got a problem, they come and knock on, you know, my door or somebody else's door in the practice to help solve that issue. You know, we emphasize to our patients that they're seeing PAs, not necessarily GPs. I think there does need to be that discussion though with the entire public about the fact that there just is not, and they.
So Gandhi pausing there, but I know he's going to be saying there is not enough GPs. You know, and if people need and want GP appointments or appointments at their, you know, at their general practice, then it's not always going to be with the GP. It may be with other members of the team. I don't know if Gandhi's phasing himself back in. now. Okay,
Sorry,
you're back.
everyone. I think my IT, my internet went a bit doolally
You're
just
fine, Gandhi.
there.
Can I ask you a question, Gandhi? Because obviously you work with PAs day to day. You know, had they seen this report? Had the patients seen this report? What sort of impact had it had on the morale of the physicians associates or attitudes of patients at your practice this week, if any?
So interestingly, both the PAs in my practice have decidedly made the decision not to.
Not to watch it, I guess is what Gandhi's going to be telling us. And I often avoid bad news. Just waiting for Gandhi to phase back in, as I'm sure he would. Um, I'm
Sorry,
assuming
everyone.
that
I seem to be having some internet issues today, which is a bit unusual. Doesn't
yeah.
happen.
I mean, you can go all audio if you need to, Gandhi, so that we
I
can
think I
keep the
might
show on.
need to. Yeah, I think I will just do that for temporarily.
Okay, so we can't see Gandhi, but Gandhi is there. I bet we can hear him. Any patient fallout for you guys at your practices, Gandhi? Lost him completely. I'm going to bring a
Mm,
comment up onto the screen while we're just waiting for Gandhi to come back and sort his IT out. So S S23 said, I thought it was unfair. PAs have their place in the system, and the public opinion seems to be that they're there to replace the GPs, which I guess is not, which is not the place. They're there to augment the system, and when used properly, they're there to augment the system and ensure that there are more appointments available through the system. Um, I guess if Gandhi was here, I'd be asking, so what are the differences between PAs and GPs? And obviously, GPs, go through 5 years medical school, and there's normally some period of time working in hospitals for 2, 3, sometimes more years, and then a 3-year GP training scheme before you're a junior GP just joining practice. PAs, I gather, do I think Gandhi must have switched off and been rebooting his computer. PAs do normally a 3 or 4 year degree, and then do a course for 2 years, I think, before they're a junior PA, at which point they need lots and lots of support. And it's very clear. And I know when we were considering working with PAs, which we didn't in my practice in the end, and that was because we just felt we couldn't at this point in time deliver that level of support and supervision to them. And I think that's where there were issues within the Panorama report. Gandhi's back. Hopefully,
Fingers
you're a bit
crossed.
stable. So,
Sorry.
Gandhi, I've just been rambling on, but so I had a few quick questions for you about PAs, actually.
Go
So
for
you've
it.
been working with them. Is it working well? How are you finding working with PAs?
So I think it works really well. I think they have amazing skills in terms of breadth across the entire general practice, and they have a diverse training compared to some of the other, particularly the PCN roles like the pharmacists, which are very much more medication based, the physiotherapists, which are more MSK based and stuff. So they can do that whole aspect of supporting the primary care team. And I think you will also have experienced PAs out there who have been working effectively. So we've had one that's been working within 3 years in our practice supporting us with, our triage clinics, and that's one of her main roles. And she is probably the most effective triage clinician in our practice outside of possibly myself and one of the other GPs in the practice in terms of experience. So, it just goes to show it's about the training, it's about the supervision, and it's about the person, let's be honest. I think the role allows them to do certain things. I think, and I'd echo that whole point of supervision is paramount to make and support them to be an effective clinician, and also making sure that they're not working outside of their competency, because that's where it gets unsettling, and then that's where it gets challenging, and more importantly, that's where it gets unsafe. So it is about the supervision, and we were keen to invest that time, and this was pre PCNs, this was pre COVID as well that we invested this time. Since then, we've taken on another PA within the practice and a few within the network, and generally speaking, it's been a positive experience, but there is that onboarding time that has challenges for many practices, and we know about the workforce challenges across general practice, and that's where I think, like you said, like in your network, you felt that supervision time was not something that you could invest at this point, and that makes it more difficult because there's no point taking on these staff members and then just leaving them to run when they need that support in order to be effective. And if you can do that, it's great. If you can't do that, then I question what's the purpose, what's the place, and what are you aiming for and stuff. Like I
Yeah.
see, we've got some questions coming up. Maybe we're taking those, Andy.
Yeah, go for it. Let's value some of the comments and just bring them on. So, Tom Tim just reflecting that in his opinion, sometimes misused. I've seen them do cancer 2-week wait services and potentially send a lot of people down those pathways, which is often not helpful to our secondary care colleagues or to the patients who might worry unduly, I guess.
Well, I'd question that in some ways. So two parts to that. Number one, there is this assumption that currently general practice does under-refer to cancer pathways. Secondly, there's that aspect of actually, one of the things that we do with RPAs is every referral they want to make, they discuss with a GP beforehand to make sure if it's appropriate and if there's other services or other considerations that need to be made. So again, I'd put that into the question of how is the supervision working? There
Yeah.
possibly is that element that GPs have a broader training, so therefore, in terms of lateral thinking, may be more effective. But I think it's important to recognise. I don't think you can just put that down to the role unless they're working, without the relevant support.
Yeah, and I think I'm not sure Tom's necessarily putting it down to the role, but just he's seen that happen within the system, the way the
Yeah.
system is set up, and I can see how that might happen without the sort of safeguards that it sounds like you've got in place in your network. This is really I was going to ask about the actual impact for practices and patients.
Mm.
So when you look at the GP appointments, how much you need to take out from a GP's time to supervise them, and how much do you get back in through the work done by the PA, and does that square? Have you got any comments about that, Gandhi?
So, how long is a piece of string is the answer to that one. So, this massively depends on the relative experience of the person that you're supervising. This depends on the individual themselves and how much confidence and capabilities they have. And it also comes down to the supervisors, capacity and capabilities as well. So, I'm a GP trainer. I would say I've got reasonably good, experience and confidence in supervising somebody and how to do that. But compare that to some of the other clinicians in my practice who may not have as much experience. They may feel they need more time to do that because they haven't had their own experience and stuff. And then it's also the complexity of what you're asking them to see. If you're asking, these clinicians to see really complex stuff, they're going to need a lot more supervision and debrief time. So the general rule of thumb we have is that we aim that however many appointments we take out for supervision is always slightly less than the amount of appointments the person is actually seeing. So at least you're hopefully always in a net positive in terms of that. And that generally does work out all right speaking, but the challenge comes when you're supervising multiple people. That's when it gets more complex.
Yeah, no, that's really good principle to apply, Gandhi. I often sort of I often think about these kind of questions, and increasingly in the last few years, I've come to the conclusion that actually, well, she might ask, "Oh, what's the data? What do studies show?" Often it's very difficult to replicate the effects that you get in studies in your particular practice. You might actually find that because of the people you've got and the type of physician associates that you might be able to recruit, that you actually perform better than you might find in a study, or you might find that you perform worse because you're doing it, without people being on board and without the right people. So I think it's good to have these things in our toolkit. I don't think they're going to be the right thing for every practice, but for some practices and some people, it's going to work really well. So
Yeah.
I welcome it in the toolkit, but I feel that we shouldn't be necessarily making kind of broad policy decisions necessarily that everywhere needs to have these people, because I think that's where you can run into problems and negative impacts. Jace Melody just saying, yeah, people get exploited everywhere,
Yeah.
and I think guess she's feeling it a little bit for these PAs that were involved in this Panorama program in particular, and perhaps more widely. And I have sympathy for them as well. It's horrible when you get involved in these kind of things. PAs versus AMPs, because we use a lot of AMPs. They weren't always popular. There
Okay.
was a similar debate a few years ago, potentially around AMPs. Any? Do you have any opinion if you use both, Gandhi? Oh, Gandhi,
Sorry.
we're having Gandhi is stuttering again. What we might do is when he comes back, perhaps begin to move to the final story. We've limped through on Gandhi's IT. Let's get over the finish line. Are you there, Gandhi? You might need to switch your video off, Gandhi. That might be the answer to get you through the end, because I know this next story that we were talking about is that Capita have again secured a renewal for their contract to deliver the primary care support services, which involves them doing all sorts of things to support primary care, moving notes and information around and data around, administering our pensions. And they've had their contract renewed going forwards. Happy people want to comment on this as well, whether people think that this is a good thing or a bad thing. Um, I think generally people worry that they don't do a good enough job at looking after these elements of their contract for primary care. I know I've had difficulty getting, as I say, a total reward statement of my pension for a while, despite lots and lots of emails and lots of telephone calls. So I've had some personal experience of that not working very well. Gandhi's dropping in, just talking about PSE and that they have had their contract extended to provide primary care, support services. Gandhi, what do you think about this?
So, firstly, apologies, everyone. I have no idea what's going on with the internet today. I suspect someone's probably draining us down somewhere, but I'll need to look into that. But yeah, PSE and the contract. So, important to note that this was a contract that was agreed 7 years ago. It was originally designed to be a 10-year contract with a 7-year break, like most significant contracts tend to have. And it was extended for another 3 years, is the information we have. Obviously, this challenges the fact that this was held by Capita to provide what's called PCSE services to primary care. This is a lot of the admin support, so things like management of notes, pensions, and a variety of other functions that they provide. As we know, over the past 7 years, there have been massive, massive challenges for many clinicians, GPs, practices in terms of this. There's been questions about data security and safety when it came to patient notes in the initial outset because it just wasn't working. There were periods where we were not getting patient notes 6 months to a year potentially after a patient had registered because of the challenges. And I think many people working in the grassroots feel that this is
We'll lose you again, Gandhi, but we're nearly there at the end. The most telling comment in this for me was Capita told Pulse that NHS England was happy with the service provided. The contract had been extended for the remaining 3 years. When you talk to people about some of these contracts that underperform, often the answer I get is actually they're not for great sums of money, and actually these companies are not necessarily resourced very well to deliver on these contracts. And often these contracts are for peanuts, and that's why you sometimes get monkey service. So some of the blame here is not necessarily, you can't lay all of the blame, I think, at the provider's doorstep. There's something about the people who commission these services, decide how much they value what they're doing, and that reflects in how much they pay for the service, and then ultimately, renew these contracts and continue these contracts, even in spite of criticism. So just some comments here. Absolute disaster. If they were a GP practice, CQC would have shut them down. And my encounters with PSE has generally been poor, mainly around registrations, and I would reflect that really in terms of my contact with them around sorting my pension out. So thanks for joining with us. I mean, despite the technical difficulties that we've been having, it looks like we've had a lot of people stay with us to the end, continue to comment. Ed, nightmare, trying to get GP codes, etc. So Gandhi, you're back. I was just beginning to wrap up, just thanking people for bearing with us despite the technical difficulties that we've been
sorry,
experiencing.
everybody. Really sorry.
Many people have stayed with us at the end, continue to comment. I'm sure we'll be back with another update episode soon. I guess we might leave it there. Any final words, Gandhi, if you can stay connected for long enough to deliver something?
So I think one of the things we have had as a theme from today's episode is about companies coming in and how this works within the NHS and stuff. And I think one of the things that we're going to look at in one of future of our episodes, which are probably coming up somewhere around here and stuff, is what does private companies coming into the NHS actually mean in terms of the pros, the cons, and the various different aspects and stuff. So definitely check out that episode. We linked some of our previous episodes down in the comments and the description and stuff. So do check that out, as well as the links to all the news stories we've covered. And as always, here on eGPlearning, we're here to help tech enhance your primary care and learning. And we'll catch you in the next episode. See you later.